All right, good morning, everyone. I'm Natalia. I'm sure you all know me. Today I'm going to be giving a talk about medical malpractice as part of the admin lecture series. Please excuse the spelling mistakes on this AI-generated image. So just a little outline. Oh, hold on. 1 second. Sorry, guys. All right, here's the outline of today's talk. So we're going to go over some history and background, some statistics as it pertains to emergency medicine, some malpractice reforms that are current and possibly ongoing in the future. We'll go through a case and then go through some key takeaways. So I like medical history, so I thought this was interesting. So the idea of doctors being responsible for their actions dates back thousands of years. The first documented mention of medical malpractice dates back to 2030 BC in the Code of Hammurabi, which is one of the earliest and most complete written legal codes that was proclaimed by the Babylonian king. There are sections about repercussions for medical mishaps, and the code says that the doctor should be punished if the doctor makes a mistake causing harm during surgery, such as this one I have on the screen. And this was done in order to prevent the strong from oppressing the weak. And then some more history since then. So in 500 BC, we have the Hippocratic Oath. In 1374 is the first recorded medical malpractice case when a surgeon tried to repair a woman's mangled hand unsuccessfully. The judge stated the physician could be held liable when negligent, but if properly treated, not liable just because it could not cure the patient. In 1794, we have the United States' first medical malpractice case, which occurred when a woman died after a surgeon promised to perform a surgery successfully, and the husband was subsequently awarded 40 English pounds. In 1835 to 1865, there was a large increase in the US of cases that were mostly involving orthopedic fractures and dislocations. And this uptick in cases was an attempt to prevent amputations. In the 1970s, courts began publishing standards of medical malpractice awards, which led to one of the fastest growing periods for money being awarded. And as a result, almost every state passed reform laws to try to keep physicians' insurance premiums down. And some states even capped the amounts for certain types of damages. And then in 1984, there was an 18-year-old by the name of Libby Zion who was admitted to a New York hospital and died while being treated by 2 residents. This led to a highly publicized trial, which ultimately led to new legislation and duty hour restrictions in New York. And then the ACGME officially adopted similar duty hour restrictions in 2003. Most recently, in 2011, I didn't include it on the slide, but the National Conference of State Legislatures recognized a growing problem with medical malpractice and created goals for reforms of the system to limit cost, deter medical errors, and to ensure fair compensation for harmed patients. And we'll go through that a little bit later. So we're going to go to law school for a quick 5 minutes so we can better understand the terminology. So within US law, there's criminal law and civil law. Civil law typically involves a dispute between 2 parties in which the plaintiff seeks compensation for an injury arising from the alleged wrongdoing of the defendant. Within civil law, there is tort law. So tort law is a set of laws that addresses civil wrongs that cause a claimant to suffer loss or harm. So I didn't understand the difference between tort law and civil law. Pretty much tort law makes up like more than 90% of civil law, and then the rest is just made up by contractual disputes. And then medical malpractice falls under a subset of tort law known as professional negligence. So as a disclaimer, anyone can sue you at any time for anything. But when it comes to medical malpractice, in order to recover losses from a negligent physician, there are 4 key elements that the plaintiff must demonstrate. So there must be a duty to treat, which is established through a physician-patient relationship when the physician agrees to undertake diagnosis and treatment of the individual. Next is breach of duty, which occurs if the physician did not provide the appropriate standards of care. And within the emergency medicine community, standard of care is typically evaluated by using expert witnesses who will cite textbooks such as Tintinelli's, Rosen's, and practice guidelines created by organizations like ASAP. Next, so damages. They're meaning that there was harm caused to the patient, typically in the form of physical injury, emotional distress, or financial loss. If there is no harm or damages, then there can be no negligence. And last is causation. So the breach of duty must have caused those damages. So there has to be a direct link between the breach of duty and the patient harm. So how does this apply to emergency medicine? So within emergency medicine, there are unfortunately a lot of factors that can predispose us to risk of litigation, with some of those being we work in a high stakes and high acuity environment. We're working on limited patient information. We frequently have to make quick decisions. We're constantly cognitively overloaded. We have high patient volume and rapid patient turnover. So how does this actually translate to our risk of litigation? The data varies. However, this chart here is from a study published by the New England Journal of Medicine in 2011, which found that EM physicians have about a near average risk of being sued compared to other specialties. However, there's also other data. So in 2016, the AMA found that about 51.7% of EM physicians have been sued in their lifetime, which is actually third most likely behind OBGYN and general surgery. This risk increases with age, but that's to be expected given people are in the field longer and thus have a higher chance of being sued. Regardless, the risk of being sued is still high, so it's important to have the right information, be prepared, and know what to expect. So here are some characteristics of EM malpractice cases. So this was pulled from a study by Myers et al. That was published in 2020, and it analyzed claims closed between 2007 and 2016 for 3 different specialties, being emergency medicine, internal medicine, and general surgery. And these were only claims for adult patients. This data came from greater than 400 hospitals and more than 160,000 physicians, and it represented more than 30% of all the claims in the United States at that time. There was a total of 54,772 claims, but only 2,760 of those were involving emergency medicine physicians. So here on the screen is the data based on the characteristics of those claims. So in terms of the allegation, the most common is diagnosis related at 58%. Then we have medical treatment and procedural complications. And within procedural complications, just so you all know, the most common of those are intubation, which is 7% of all procedures, suturing, which is 5%, and lumbar puncture at 3%. And then in terms of the final diagnoses, acute myocardial infarction, which is the most common, followed by PE and cardiac arrest. So here are some more claims characteristics. So out of the emergency medicine claims, 858, meaning 31%, got any kind of claim payout. The median payout was $206,000, but that spanned between $55,000 to $527,000. So malpractice reforms. Fortunately, there are a lot of organizations, including ACEP and the AMA, who are advocating for malpractice reforms. And the goals of this are to ensure patients who are harmed by medical malpractice are made whole and to limit unnecessary or excessive payouts. And then the benefits are to decrease financial burden on the healthcare system, reduce defensive medicine, and ensure patients receive fair compensation. So there's a couple that have already come out, and there are more in the works. So some of the big ones, the first one being apology laws. So this is one type of reform which allows physicians to make apologetic statements to their patients about bad outcomes or medical errors without their statements being admissible in court. It's intended to open communication and empathy, although the evidence has been pretty mixed as to whether or not this actually leads to a significant decrease in litigation. Regardless, some studies do show some benefit, so it's important to know the apology laws in your state. And just so you all are aware, New York State has actually no protection. Another big reform is caps on damages, and 26 states now have some type of limitation on damages. Several states have shown success at reducing payments to plaintiffs and reducing the cost of malpractice insurance premiums for physicians. Some other tort reforms that have passed include statutes of limitations. And again, so you all aware, New York State statute of limitations is 30 months. Another one is attorney contingency fee reform, which limits the amount of a malpractice award that a plaintiff's attorney may take. And there's pretrial screening panels, which review a malpractice case at an early stage and provide an opinion about whether a claim has sufficient merit to proceed to trial. Just so you all aware, typically, a negative opinion does not actually bar a case from going forward, but but it can then be introduced by the defendant as evidence at the trial. And then there's also periodic payment, which allows insurers to pay out malpractice awards over a long period of time rather than in a lump sum. Like I mentioned before, there's a lot of organizations that are working on additional reforms. So some ideas that have been suggested include health courts, which are specialized courts for handling malpractice claims. There's also liability safe harbors for the practice of evidence-based medicine, expert witness qualification requirements, and early disclosure and compensation programs. All right, so now that we've gone through all the kind of boring stuff, I wanted to discuss a case. I pulled this from Medical Malreviewer, case number 9. And so we'll highlight some takeaways. So the case, the chief complaint on the first visit is abdominal pain, and it's documented that there's a 47-year-old who presents 16 days status post gastric bypass with wound dehiscence around the JP drain, purulent drainage, and pain. Her vitals are significant for a temperature of 100.3 Fahrenheit. Her heart rate is 114. Very mild hypertension. On physical exam, the patient's in moderate distress. The abdomen is tender with ecchymosis on the right side in the drain in place, and the incision has purulent material and surrounding cellulitis. Labs and CT. So labs are mostly just significant for slight leukocytosis with a white count of 15.9. And then the CAT scan shows subcapsular liver fluid collection, blood from injury to liver versus bile leak, abdominal wall inflammation at incision site with no definitive fluid collection, and then also post-operative ileus versus developing partial small bowel obstruction. And here is the documentation from that first physician. This is the disposition note home. So it says, I called Dr. Blank, who did her bariatric surgery in blank, to discuss the case with him. I told him of her symptoms, including the right and left abdominal pain. I told him of the cellulitis at the incision site and the draining of the abdomen, as well as the findings on CT, which show the subcapsular fluid. He told me that during the surgery, the patient bled a fair amount, which actually, sorry guys, it's very small, which actually caused him to leave the JP drain in longer, and he felt that the subcapsular liver fluid was likely old blood, given that there was no obvious liver injury on CT scan. Given that her H&H is stable, he does not feel she is actively bleeding. He is going to continue to leave the JP drain in. He asked me to do an IND on the incisional abscess packet. I will place her on antibiotics with Bactrim, refill her Percocet to last her until Tuesday, and he will follow up with her on Tuesday. I explained this plan to the patient. She was comfortable with the plan. So a little summary about the disposition. So there's detailed documentation of the discussion with the bariatric surgeon. The physician provided explanation for the subcapsular fluid. They decided on a plan with both the surgeon and the patient, arranged for close follow-up, and reviewed specific strict return precautions. So unfortunately, here is a second visit 2 hours later. The chief complaint states severe pain, and the vital signs, as you see, are significant for a heart rate of 132, and in blood pressure, it states none listed. And she's tachypnic to 37. And here's the documentation from that second physician. The notes just states, quote, CT scan earlier was fine. And then the clinical impression states abdominal pain post-op and then wound infection. So that's pretty much it. The summary here is that there was no repeat testing done. The final diagnosis is listed as post-op pain. The discharge heart rate is 142. And the dispo note states home, quote, NPO times 24 hours, sip/water and meds, may have small piece of toast. So unfortunately, the patient outcome is that the patient's husband finds her deceased in bed 4 hours after discharge. And on autopsy, there was 5 liters of purulent hemorrhagic fluid in the abdomen. So on the same vein as Dr. Desai's documentation lecture just before me, documentation is extremely important. So this rubric comes directly from the Med Mal Reviewer site, and it's what they use to review and grade the documentation for these cases. So for the first for the first physician, overall, it was deemed as a fantastic note. The couple of key points about their discussion that I think are worth mentioning are that they commend him for, rather than simply copying and pasting the results of the CT scan, the physician indicates that he comprehends the results and is able to synthesize it into the care of his patient. So he actually interpreted those CT scan results instead of just copying and pasting them as we frequently do. And then one area that they said could be improved in the first physician's documentation, it's not something I included in my brief summary, but he didn't really reassess her response to the treatment that he provided in the emergency department. There are some nursing documentation stating that on initial arrival, the patient's pain was a 9 out of 10. It then improved to a 4 out of 10, however, then got worse, back to a 9 out of 10 prior to discharge. So an assessment of this change and the improvement in her vitals would have been good to document. So moving on to the second doctor. What they wrote in the med-mal review case on the website, I think summarizes it perfectly, so I'm just going to read it to you all. The note from the second doctor was unfortunately a disaster. It is brief and provides little insight into his thinking. It is very confusing to review the record and try to understand why he sent the patient home without any further testing. Even the EMS crew wrote more than him. His note provides no rationale for the bizarre and dangerous decision to discharge her home. So the big takeaways here for me are the importance of documentation and the importance of bounce back visits. I think it's very common for providers to have premature closure when it comes to patients who return to the ED and to even view bounce back patients as an annoyance. However, instead, we should be on high alert when it comes to these patients and consider obtaining additional or even repeat testing. So the medical malpractice case outcome is that both physicians were named in the suit, but only the second physician was deposed, and the EM physician group ultimately settled the case. So obviously this case is pretty extreme. I would hope that none of us would be that second physician. But I think the big takeaway here is to, again, like I mentioned, documentation is key, and also just ensuring reassessment frequently for these patients. So takeaways from my presentation: keep up to date with practice guidelines. ASAP is a great resource for free clinical practice guidelines. Just care for your patients with the best quality of care you can. I think we all do that. Make sure to follow up on any laboratory or radiology tests you order that return after the patient leaves. Inform the patient about any incidental findings and document that you informed the patient. Complete consent forms and discuss risks and benefits for any procedure that you perform. Again, documentation, and then be familiar with your state's malpractice laws and ultimately advocate for reform. All right, thank you so much. And these are my resources.